So let's
Hmm.
turn a little bit now to how your understanding has developed in formation of your best practices. And can you go back to explaining the premise of instability demonstrated by the lack of muscular control and how you've used this and it's led you to develop your active protocols for your patients?
Oh, yes, absolutely. That's a tall can of worms. So basically, when you have a joint that's unstable, you've got ligaments that hold the two bones in that joint together passively. So if you were completely anesthetized or completely passed out, the ligaments would suspend and hold those bones properly together so that nothing dislocated, in a simplified, fashion of explaining this. But you also have muscles that span that gap that have a particular tensile strength or a tensile um, background length that is dictated by those ligaments. And so when the ligaments in this particular joint are injured or stretched, that means that those muscles will get put under a larger tensile load, which they're not hardwired to have naturally. And so they're constantly being stretched past their norm. And we're maybe talking millimeter. So this isn't, gross, large scale stuff. And because these little deep muscles that are just outside of the joints have an involuntary mechanism that causes them to contract, so we can't will them to contract. So what happens is when you have a joint that's too sloppy, the ligaments get their tensile point at a later fraction of a second than they normally would. So if this is normal, then the muscles don't get put under stretch. But if it goes beyond that, now all of a sudden the ligament comes tight at a later moment because it's been stretched and damaged. Now the muscle that spans that same gap also gets put under a tensile load. And the little sensors in that muscle then send a signal to the spinal cord. The spinal cord then sends a signal right back to that same muscle and tells it to contract to try to bring, this thing back to its normal length at the where the ligament should have stopped that motion. And so the muscle continually undergoes this stretch and then reflex contract phenomenon. And as it repeatedly cycles through that, it also starts to then send information not just into the spinal cord to come back to make the muscle contract like a reflex. It starts to also transmit information up to the brain or the central nervous system. And then the central nervous system sends another signal down through another nerve pathway that forces that muscle's resting length to slowly shorten. So that basically it increases its resting tone. So each muscle in our body has a resting tone to it. Otherwise, we would be really floppy. And so all of our muscles are under some level of tension naturally to keep us, tightly packed beings. And when you have ligament damage in an area, those muscles increase their tone to compensate for that ligament damage. And when they increase their tone, they reach a point where they're no longer functional. They literally go one ratchet cog too far where you can't tighten them anymore and you can't get them loose, at least not easily. And so then that muscle becomes non-responsive. And if it becomes non-responsive in a shortened phase, which it does, what it ends up happening is it ends up actually causing a subluxation. So something would get misaligned by that excessive tension. And if that happens at, the C1, C2 interface, you could have brainstem irritation or light brainstem, compromise due to the fact that this muscle has gone into its shortened state where it's no longer able to stretch and contract and reflexly do its thing, causing a subluxation because now it's actually locked down, and it may have caused, this kind of an offset at C1, C2 that maintains a little bit of a longer time period because a seized muscle takes quite a while to, unlock itself from that naturally so that things can, sift back into proper position and take less and have less effect on the brainstem. And so this whole process happens all the time. And this is why people that have, injured joints inevitably, repeatedly, no matter what treatment is thrown at it, they always regain that tight area that is very specific to their injury. So someone always saying, it always gets tight here. It always gets tight here. My left shoulder blade is always tight. And that's because they've damaged the ligaments in and around that area, whereby these muscles undergo this whole phenomenon, like I was saying, to protect themselves, and also then possibly creating what would be then deemed a subluxation if it's in the spine, right? And so the technique that I've figured out, and this, I learned this in school just superficially in chiropractic school. It's called Nimmo Receptor Tonus, and Dr. Nimmo was a chiropractor, back in the 30s, 40s, 50s that designed this, and he had quite a bit of scientific foresight, if you will, because a lot of the stuff that he talked about back then and published in articles has been proven scientifically. But basically, he said that subluxations would cause these, muscles to undergo this increase in tone, and by pressing on them, you actually can reset that tone interface. So the muscle then regains its ability to be stretched and sense that stretch and respond by contracting, either creating a subluxation when it's elevated its tone, or maintaining a non-subluxation or a non-misalignment state when it can properly govern those bones by sensing the stretch and responding by contracting and playing that fine, finesse dance for whatever period of time until they can no longer do that properly. And then you have what would be a subluxation in his eyes that isn't a simple bone out of alignment, bone on bone out of alignment. It's being dictated by these muscles elevating their tone. And by pressing on them specifically, like he was saying, you can actually reset that interface where those muscles then properly govern the positioning, and your misalignment is then mitigated by the neuromuscular interface and the sensor system that we have hardwired in all of us.
So this allows an opportunity for the musculature to readjust to a more stable environment and reduce the persistent misalignment.
Yeah, so it's basically an accelerated or an expedited reset of the overuse of a muscle so that it becomes active and responsive again. So I always say that I rarely meet somebody who's got weak muscles in their neck. I meet a lot of people whose muscles are non-responsive. So they've gone into that lockdown, elevated tone state where they're not able to do what they're supposed to do. And they are able to do that if you can get them out of that state. And all it takes to get them out of that state is sustained pressure.
So could you go on to explain then if imaging would be useful to enhance the precision of your technique and tailor the regime to the patient? So let's just take an example of a different injury pattern. Let's say I'm hit at a high-speed T-bone, motor vehicle accident. Another patient is hit at the front. A third patient is hit at the back. We're all physical trauma patients, for example, and of course on a soccer field. I'm sure there are many different variations. But can you speak about how you would connect that back and if imaging is useful?
Absolutely. The vectors, so again, with vectors, the vectors of a trauma are super important to be able to predict, I guess, in a very strongly educated way, which tissues, so ligamentous tissues, would have been put under tensile load and been, set up for possible failure so that you can know that the actual specific muscles in and around those specific ligaments, whether left, right, front, or back, would be now put into this predicament of, trying to hold this stuff in alignment because the ligaments no longer passively are doing it effectively. And so you can predict that to some level by just the history of the patient saying, well, I was, looking to my right, waiting for a clear spot so I can, turn to the left, and some guy rear-ended me from behind. So they were predisposed in a right rotation sort of phenomenon. And I know which ligaments would have been already in their tensile position at the moment of impact. So that when you have the impact, especially if they're not expecting to be impacted, now those ligaments are going to have been the primary resistance force for, preventing sloshing around or shearing around of bones in the spine. And then you can say, well, these are the ligaments that I would predict to have been, damaged or injured. And then you can follow that up with a motion X-ray to confirm that, and to then better direct the Nimmo to specific areas where it ends up being such that less treatment is more effective because you're really specifically going to the areas that you've seen on motion X-ray as being unstable, again, front, back, left, or right, so that you're not just trying to hit everywhere where the person has symptoms, but you're literally localizing it to where you've seen that there is ligament damage and can expect the muscles that are in that local area to be working overtime doing this and being sort of the epicenter of the problem that can then collaterally, through domino effect, affect other muscles that are more superficial, that oftentimes are the ones that are getting treated, and the deeper ones that are surrounding those ligaments are not being treated. A, because they're not thought of generally, and B, because they're 5 and 6 layers deep. So even if you are in the general vicinity and you don't push hard and deep enough, you're not actually going to get to them to reset them. And so when new patients come in to see me, especially when it's a sort of an automobile collision where you really want to know whether that particular event caused the particular problems that the patient is presenting with, having a very detailed history of their exact position at the time of impact and where the impact came from will be able to then put in a predictive phase of, hey, now we're going to do the motion X-ray and see if we can confirm what we thought should have been injured in this type of scenario. And then you can siphon out, what you would say, okay, this was caused by this, and you find other stuff that doesn't make sense. And then you can predict and say that this is likely pre-existing, for example. So you can apportion to some extent, current injuries that you would expect with the history that they've told you, so their positioning and then where they were hit from, to other stuff that doesn't really fit into that perfectly, where you can say, well, and then you can look at the, the bony detail from other types of imaging like x-rays and CTs, and see that there's potentially some mild subtle degenerative changes, which would tell you this was not a current thing, but maybe it happened 5, 6, 10, 12 years ago. It doesn't mean it's not relevant, but it means that it's likely not as a result of this recent impact.
So it sounds like this is a very intricate process where the level of details are very helpful to personalize, identify the particular areas of injury, and then from there tailor the regime.
100%, yeah. Because like I said, where people feel their symptoms and they get treated, for example, traps, levators, like the usual suspects that you hear, massage therapists and chiros and whoever else talking about. Yes, they're affected, but my experience has been that that's collateral damage from the true muscles that are actually at the bottom of this problem, which are literally spanning only one segment, whereas the traps, levators, and these things will span like 6 or 8 or 12 or 14 segments of the spine. And so they're just movers and they're not stabilizers. And so once the stabilizer sees, then you get the next level, being recruited to do that, and you get the next level, and eventually you get tight traps. And so by just addressing the traps and forgetting about the fact that there's, another 5 layers from there towards the bones that would be affected in this too, it's not as effective as of a treatment. And the efficacy, I think, doesn't last as well. I know it doesn't last as long because I've seen the evidence of that. So the deeper you can get and the more the person can handle as far as understanding, why you're doing this and what the intent is, if you've explained the neuromuscular physiology to them and they can grasp that to some extent, then they can handle the deep pressure, because there is a means to an end, and it's a goal that is intended to allow their normal involuntary stabilization mechanism of these deep involuntary muscles to actually properly function for a period of time.
And just a question regarding the spectrum of patients that you have found efficacy for. Would you say that this also applies to patients who are not just mild, but moderate to severe instability patients, but for example, cannot find proper access for care to a neurosurgeon and so on?
Yeah, I mean, every level of severity. I mean, the positioning is crucial to not allow for, when you performing the pressure on their muscles, to create this kind of shear motion, so you can properly position somebody's neck where you mitigate or minimize that happening as you're pressing. And so the severity of the patient is not a predicator of doing it or not doing it. What I have found oftentimes is the ability of patients who are dealing with these uber severe symptom patterns, and that are expecting something extremely complex as an explanation to the solution to their problem, have a really difficult time in understanding and accepting that acupressure, or this Nimmo Receptor Tonus technique, which is literally just pressing on the appropriate tissues to get this reset to happen. How can it possibly be that simple? Because then everybody would be doing it if it's that simple. So the complexity of what they're expecting to hear sometimes predicates their acceptance of this as a possible solution or a temporary solution to the problems they're having. That's what I found to be the biggest disconnect. And for the vast majority where this type of technique isn't going to be as effective, is their lack of ability to put it into a place where they're willing to say, okay, maybe simple is a possible solution.
Yeah, I can appreciate the disbelief, but having said that, once patients that have structural biomechanical issues have partnered with someone that really understands their specific precise issues, and they found an exercise regime or something tailored to them, exercise would be too strong a word for this issue, I've seen huge benefits, but it does require time. And so a daily regime and routine and self-management is a key part of it. You've also mentioned that massage therapy, patient can work with a massage therapist. So can this technique to reset the muscles be transferred to both the therapist and to the patient, integrated into their daily routine? Do you see this as practical?
Well, I've seen it as practical, of course. Yeah, I've actually experienced that. Again, I'm talking about large numbers of patients here, but there is a good percentage of patients that do embrace this as and understand the physiology as I explain it, and are willing to embrace this and try it on themselves, and potentially even have their local chiropractor from wherever they are, or their local massage therapist, whoever is willing to do manual work on their muscles to embrace, using this technique or using a version of this technique to mitigate the problems, and then learning themselves, which is far more important than finding a practitioner to do it on them, but learning themselves how to self-administer, because the fix is not permanent, because the reset of the muscles isn't fixing the problem, it's fixing the things that are causing the symptoms that you perceive temporarily, because the true problem is the permanent damage to the ligaments, which renders the joint or the joints unstable, causing the muscles to undergo this phenomenon in a protective and a proper governance phase, only to then fail at the end and seize, needing to be brought out of that lockdown seized phase so that they can properly manage that instability for a short period of time until they seize again. And so being able to perform this on oneself, 2 times a day, 10 times a day, whatever it takes to maintain that status quo where those muscles are doing that, is far more important than having a therapist who you maybe get into once a week or once or twice a week or whatever the frequency is, to have them passively do it to you.
Thanks for introducing the merit of this technique and the frequency, and that it's required as part of a regular ongoing regime to commit to for purposes of seeing change, positive change. You've talked a little bit about your story. Often where we begin is not where we end in life. So can you tell your story as to where you started with your education and really how it ties into your approach today?
You mean chiropractic education?
Yes.
So yeah, that was in Portland, Oregon, at what was back then Western States Chiropractic College, which is now the University of Western States. I would say it's a very scientific chiropractic university that delves in all sorts of different scopes of possible practice for chiropractors, because Oregon has a very broad scope for chiropractic because of the vast rural areas there. So you have chiropractors in Oregon delivering babies and doing OBGYN exams and proctology and all these different things and doing minor surgery. And so we were exposed to all of that stuff, and also obviously to soft tissue techniques in addition to just adjusting the spine. And so my first exposure, like I said, was in our soft tissue classes to Nimmo. And I was like, well, okay, whatever. Just push on stuff and so be it. And lo and behold, I was having a headache one day, and I went to the junior clinic, which is where I were at that stage in my education. That was where I would go for treatment if I was a patient. And so I went there, and it was closed. And it just so happened that my supervising clinician, who oversaw the other chiro that would then be my doctor in the junior clinic, she was there doing paperwork, and I went in there to see if I could find somebody, and she was the only one in there, and explained to her what was happening, and she said, well, let me take a look at you. And I was like, oh, here we go again. I'm going to get adjusted, and it's going to be great for 10 minutes, and then I'm going to get dizzy, and which is with the usual response, and then my headache's going to be worse. And so I let her check me out, and she's like, well, I can't try something on you. And she literally just, had me laying on my back, and she, lifted my skull from behind and pushed on these muscles. And she was just holding there for literally like minutes. And I was like, this is uneventful. And then she finished her thing, and I left. And, I had, for the first time, I guess, from being treated by somebody else, a more longer lasting benefit that came relatively quickly after she treated me. And I was intrigued, and then went through my chiropractic school, completely not even considering this as a technique that would be beneficial to me, until the point where I actually ended up trying what is a version of this on myself when I was having a brutal headache, when we were living in the Netherlands and working. I went home for lunch one day with the worst headache ever, and I didn't even eat. I just literally, I thought it was something out of alignment, typical chiropractic thought. And so I grabbed my head on one side and held, and I pushed really hard on a spot that felt like it was somehow connected to the brain pain that I was having. And I pushed real hard, real long. I was literally shaking. I was pushing so hard because I was either trying to, break something or force something into alignment that would have magically relieved my problems. only to realize that, nothing magically cracked. And I went back to work miserable. And within 30 minutes of being back at work, I all of a sudden felt like this headache was literally just leaving my body. It was kind of an out of body experience. And within an hour of being back to work, my headache was completely gone. This is the first time that it was something that quick got rid of my headache. And I was bouncing off the walls. I had my energy. I could multitask. My vision was clear. I literally, I felt like I could change the world. And then I didn't even think about, I was just happy. And then a couple months later, the same thing happened again. And I went home again at lunch trying to, either break my neck or knock something back into place really forcefully. And then I had the same response, within an hour of being back at work, my headache was completely gone. And before that, I couldn't even hold a conversation with a patient. I had zero energy to even do that. And then, like I said, within an hour of being back, I was bouncing off the walls again and having, elaborate explanations for patients. So I was just like almost impressing myself as to how much energy I had. And then that got me into thinking, well, what's going on here? And then it came to the epiphany after doing a bunch of research and digging that what I did with that sort of attempt to hurt myself, if you will, or do something to, explode something, caused me to actually push hard enough and long enough to get into layers 5 and 6 and actually treat the muscles that needed it, as opposed to the muscles that were more superficial, which I always used to do, because I always used to press in the area, but very mildly, and I used to rub, and it would be like almost like a distractive sort of benefit. But then within seconds, the symptoms would come back. And when I did this, I came to the realization that because I went so deep and so hard and held for so long, that I was able to finally release the lactic acid out of that layer 6 muscle that was involuntary and reset it. And when I reset it, it properly governed the position of my atlas, reduced the compression on my mild compression on my brainstem. And then obviously there's other things that I can get into, like myodural bridges that basically connect these little muscles to the actual coverings of the brainstem and brain and spinal cord, that then when they put tensile force, because the muscles have gone into the lockdown mode, they put tension on those brain coverings or brainstem coverings, and you get sort of a brain pain that would be akin to meningitis type of stuff, right? Because the meninges are the things that cover the brain and spinal cord and brainstem. So when those things get inflamed or swollen or put on tensile load, it's extremely painful. And so that all went away because of this simple, deep, sustained, harsh pressure that I did. And that sort of got me on this track where I, started researching this more. And there's a ton of neuromuscular physiology that explains all the stuff that I've kind of superficially just touched upon.
Well, thank you for very aggressively finding a solution to that headache, which really brought about the evolution of what you've done to further patients as well in their progress.
Yeah.
Where would people find you, Dr. B?
Clinically, patients that come see me in person, they go to the whiplashclinic.com. It's not the Whiplash, but just whiplashclinic.com, and all the contact information is there. And then patients from abroad that can't or won't come to physically see me, they can go to Dr. Blaskovich, so drblaskovich.com, and contact us through there to see if there's any way that we can help them. And just with one caveat, I want to just clarify one thing. I refer to Nimmo as the technique that I use. However, I have very drastically made it my own. So that's the basis of what I do, is the principles of Dr. Nimmo. But the way that that's being taught is not like how I use it. So I've basically Sashatized Dr. Nimmo's work because that's the most effective thing for me. And I've noticed that for my patients, especially this demographic of patients that's willing to allow me to do this to them and understand the reasoning behind it and the concept behind it, is more effective. And the Nimmo, the way that it's taught and the way that the principles of Nimmo are very similar, but just they push as hard and they'll push as long. And there's reasons why they don't do that they've noted in their literature. But I've taken it and done something different with it. But that's the basis of it. And Nimmo is also the basis for interest's sake to something that developed later on, and that's active release technique, which is another chiropractic soft tissue technique that stems its origins from Dr. Nimmo's work. So he's a very crucial guy in the history of chiropractic when it comes to non-spinal adjustive techniques. So soft tissue, I think Dr. Nimmo by far was a genius, way ahead of his time.
Understood. So you've modified and worked and reworked the process until you found something that was your own.
That helped me
really
better, yeah. And so that's, you could say I've made it my own.
Yeah, very good.
Yeah.
Thank you. Thank you for sharing. We'll post all the links below. the video, and thank you for sharing your time today and your great work with the patient community.
My pleasure, Athena. Thanks for having me.
Bye now.